Hello and welcome to the group room where we're at the 34th annual CTRC-AACR San Antonio Breast Cancer Symposium. I'm very pleased to be joined now by Dr. Joanne Mortimer, Director of Women's Cancers Programs, Professor in the Department of Medical Oncology and Experimental Therapeutics, the City of Hope Comprehensive Medical Center in Duarte, California. So as you've been in the sessions here for a few days now, I'd like to ask you, what has really stuck with you? What presentations and what sessions have made the biggest impact on you?
So I think one of the biggest areas of interest to me personally, as somebody who studies survivorship, is the impact of treatment on bone and how that potentially relates to breast cancer recurrences. So we heard an update of the Austrian breast cancer study where young women were randomized after treatment with endocrine therapy. They either got zoledronate or not, and it turned out that they had fewer breast cancer recurrences. And then the ZOFAST trial that looked at the use of either starting a bisphosphonate, starting zoledronate, Zometa early, or waiting until they had more bone loss was associated with fewer breast cancer recurrences. I mean, these are, and then the NSABP clodronate trial that again showed fewer recurrences. There is something that the bone is telling us about breast cancer and disease recurrence, because women who have osteoporosis very seldom get breast cancer. Yes, it happens, but it's less common. Women who have very dense bones get breast cancer fairly often. So the fact that these agents have an impact on now breast cancer recurrence is telling us something about a biology that we need to understand more of, and hopefully will help us to impact disease recurrence.
Quality of life is such an important area that you, despite your real important clinical research, that you have taken this interest in the quality of life of a patient, not just in response to treatment, but in general. You're very passionate about the way your patients live and coexist with their cancer. So since we last spoke, maybe you could talk a little bit about what you're involved in with your quality of life studies, and also maybe if you have a little living with menopause update.
Yes, so the biggest problem that young breast cancer patients have, those who either are getting chemotherapy before menopause, or even older women who get these hormones that cause them to have hot flashes and night sweats. I reported several years ago that women who experienced hot flashes actually had fewer breast cancer recurrences. So, okay, that's sort of a positive aspect to having a hot flash. But most women are actually pretty uncomfortable with these hot flashes and night sweats and difficulty sleeping and mood problems, and they need not really suffer with those, because there are a number of interventions that actually can be very effective in minimizing hot flashes, whether it's antidepressants or gabapentin, Neurontin, can control hot flashes and also help with the sleep in these women. We have a survivorship program that we enroll women with newly diagnosed breast cancers at the time of their initial diagnosis, and we run through all their symptoms and they fill out questionnaires, and then 6 months later we see them. By then they're usually done with their chemotherapy. And because we have a nurse practitioner there, we're able to ensure that if women have hot flashes and they really are uncomfortable, that we address them, problems sleeping, mood disorder. So we try to be very proactive about these side effects so that we can maximize the quality of life of these women.
Are you currently involved in some research that is ready to be discussed?
So the one study that we're hopefully going to get started within the next 3 months is a study looking at estrogen for women who have pain with intercourse. So this is a very dicey issue because we always worry about giving breast cancer patients estrogen, and vaginal estrogen applied to the vaginal area has been approved for the treatment of painful intercourse in women who have menopause. And we're going to look at it in women who have triple-negative breast cancers. Difficulty, pain with intercourse can be anything from uncomfortable to incredibly uncomfortable, and it may manifest itself, that dryness that women get as a result of menopause may manifest itself in all sorts of weird ways. I recently had a woman who developed a urinary tract infection. She was taking one of the aromatase inhibitors, had horrible vaginal dryness, and she had a very tight pair of jeans on, and that's what caused her to have a bladder infection. So it's really not just about sex. I mean, it's about bladder function and recurrent bladder infections. So I think that's an area that we spend very little time on, and one that we probably need to spend more on, and hopefully we'll come up with interventions that can be effective without harming people.
There was one study here that I don't know how significant it is, so I'm going to ask you about the diabetes and obesity increased risk for breast cancer development. I don't know if we know a lot, but I found that correlation because we've always, well, we have known for a long time now that obesity and breast cancer, this is not good, and that being overweight is a risk factor. The diabetes, which we know can be a byproduct also of weight tied to breast cancer, is rather fascinating.
It is incredibly fascinating, the diabetic discussion, because some of the medicines that we use to treat diabetes, specifically metformin, are being tested as a treatment for breast cancer. In colon cancer, it turns out that individuals who have diabetes actually do better. And so, we kind of hypothesize maybe it's because of the medicines they were taking. So in this Scandinavian trial, it was sort of interesting that it wasn't favorable to be diabetic. And whether the diabetes is just part of being obese and getting this metabolic syndrome where your cholesterol becomes elevated and you also get diabetes, maybe that's different than just diabetes that occurs at a young age or obesity individually.
And you were mentioning a drug for one indication. That was it for diabetes that you're...
Right, so metformin is a drug that's used to treat diabetes, and it actually, and it's a very common one that's used in people who develop adult onset diabetes, and it actually does have anti-tumor effects. It's really currently in trial in Canada as a cancer preventive agent. There are some other instances where the medicines we use to treat common medical problems may have effects on cancer. The lipid-lowering drugs, there's an ongoing debate about whether they lower the risk of prostate cancer or whether they alter the course of the disease. So these drugs are not they don't have a single function necessarily, and they do affect other organ systems.
Well, and I guess it's the Bolero study where a drug that was used for organ rejection to prevent organ rejection, you suddenly find in combination with an aromatase inhibitor has benefits in the treatment of metastatic breast cancer. Yes. So
yes, all these chemical pathways really do cross over from cancer to other diseases, yes.
Dr. Joanne Mortimer, Director of Women's Cancer Programs and Vice Chair of the Department of Medical Oncology, also Professor in the Department of Medical Oncology and Experimental Therapeutics at the City of Hope Cancer Center, Comprehensive Cancer Center in Duarte, California. Thank you, Dr. Mortimer.
Thank you, Selma.